Hi everybody, this is Dr. Ihab Tarawa, consultant of acute care medicine at Saba University Hospital, professor of medicine, University of Khartoum. This is the second session in basic emergency care course. This course is designed by experts from WHO for low resource country. This is session 2 is about ABCDE approach. The objectives of this session to describe how to assess and manage ABCDE component. We will start with airway, then breathing, followed by circulation, disability, and finally exposure. As we mentioned, ABCDE approach is a stepwise approach. It's designed to ensure that life-threatening conditions can be identified and treated early in order of priority. You go through the airway, followed by breathing, circulation, disability, and exposure. If a problem is discovered in any of these steps, it must be addressed immediately before moving to the next step. ABCD approach should be performed in the first 5 minutes and repeated whenever patient condition change or worse. The elements of ABCD approach: airway, and always when you are assessing airway, you have to remember or to consider if there is cervical spine injury and you have to immobilize, especially in patients with trauma, and you need to look for airway obstruction. Breathing, and whenever we are assessing breathing, make sure there is adequate move of air into the lungs. And whenever you need oxygenation, you have to give oxygen. Circulation, determine if there is adequate perfusion and check for life-threatening bleeding, and whenever there is bleeding, you have to apply measure to stop bleeding and to resuscitate with IV fluids. The fourth element of ABCD approach, D, disability, and here we are looking for any condition affecting the brain and spinal function, and we have to use some measures like AVPU if the patient is alert, responding to verbal stimuli, painful stimuli, or unconscious, or during the second survey we can use the GCS Glasgow Coma Scale, and we have to assess the pupil and to see if there is hypoglycemia. Exposure, here we have to identify any hidden injury or any environmental threats, and we have to avoid hypothermia. The ABCD approach, as we mentioned, is a structured approach designed to ensure that life-threatening conditions are identified and treated quickly and in set of priorities. If a problem is discovered in the airway, breathing, circulation, disability, or exposure, it must be addressed immediately before moving to the next step. Remember, always check for sign of trauma in each of the ABCDE sections and refer to trauma module as needed. Trauma could be severe trauma like motor vehicle accident or pedestrian hit by a car, but sometimes it could be just a fall in the bathroom. So whenever there is trauma, you have to have special consideration, especially when you are managing the airway, and you have to consider cervical spine immobilization. The first step is to do airway assessment. The easiest and the quickest way to do airway assessment is to talk to the patient. Can the patient talk normally? If the patient can speak normally, this indicates that the airway is open, and then you continue to subsequent component of ABCDE approach. If the patient cannot talk normally, does he talk at all? If he is not talking, then you need to look if the chest wall is moving up and down, if there is indicating that air is moving in and out the lung. And you need to listen for air movement from the mouth and the nose. If he can talk but the speech is not normal, then you need to listen for abnormal sounds suggesting obstruction, like gargling, like husky voice and stridor. You need to look and listen for fluid in the airway. You look for foreign body, swelling in the lip, in the tongue, and also you need to assess the mental status and check that if the patient is able to swallow his saliva. After you finish airway assessment, then if there is any abnormality, you go to airway management. If the patient is unconscious and is not breathing normally, you can open the airway with head tilt chin lift maneuver. When you do this maneuver, you want to make sure there is no concern of trauma. If there is suspicion of trauma is suspected, and then you have to maintain C-spine immobilization and you open the airway by jaw thrust maneuver. After you open the airway, consider placing like oropharyngeal or nasopharyngeal airways. In the comment section, I am going to put link to how you do head tilt chin lift, jaw thrust, oropharyngeal and nasopharyngeal airways. Managing airway, if you see fluid, you do suction, and if there is a foreign body, if it is visible, remove it gently. If the patient is able to cough and make noise, keep the patient calm and encourage him to cough. If the patient is choking, unable to cough or make sounds, use age-appropriate chest thrust, abdominal thrust, or back blow, or what we call Heimlich maneuver. And if the patient becomes unconscious while choking, then you go directly to CPR. Continuing airway management, if there is secretions, you can do suction or you can wipe it. If the other element of the airway are normal after you open the airway, then you can put the patient in the recovery position, especially if there is no trauma. If the patient has swelling, hives, stridor, consider anaphylaxis and allergic reaction. You can give adrenaline intramuscularly. Allow patient to stay in position of comfort, and then you make assessment if the patient can be managed in this facility or need to be transferred to higher level of care. After you assess and manage airway, then you move to breathing assessment. Look, listen and feel to see if the patient is breathing. Assess if breathing is very fast, tachypnea, very low, bradypnea, or very shallow. Look for increased work of breathing by the patient using accessory muscle, chest indrawing, nasal flaring, abnormal chest wall movement. Listen for abnormal breath sound. Remember, patient with severe airway obstruction, they can have no audible breath sound due to severe airway narrowing. Continue doing breathing assessment. Listen to see if breath sounds are equal. Check for the absence of breath sound in one side. Absence of breath sounds with dull percussion note indicate large pleural effusion or hemothorax. When percussion notes are hyperresonant, especially in patients with hypertension, distended neck vein, and shifted trachea, consider tension pneumothorax. Make sure to measure oxygen saturation. Managing breathing abnormality. When the patient is unconscious with abnormal breath sound, perform back valve mask ventilation with oxygen, and if needed, follow CPR protocol. If not breathing adequately, if the patient is having very slow or very fast or very shallow breathing, consider using back valve mask ventilation with oxygen. Even if oxygen is not immediately available, don't delay ventilation. You can ventilate with back valve mask with the room air and plan for quick transfer to another facility. If the patient is just hypoxic with fast breathing, give oxygen. Managing breathing abnormality when patient has airway obstruction, small airway like having wheezes, you can give beta agonist salbutamol. Those with allergic reaction, you can give adrenaline intramuscularly. When there is tension pneumothorax, you have to do needle decompression, give oxygen, give IV fluid, and prepare for chest tube. When there is a large or massive hemothorax, you give oxygen and plan for chest tube, and also don't forget to prepare blood if there is a very large blood loss. If the cause is unknown, consider trauma. After you finish airway and breathing assessment and management, you go to circulation. Assess circulation, look, listen, and feel for sign of poor perfusion, hypoperfusion, and shock. You can find cool, moist extremities, delayed capillary refill, diaphoresis, low blood pressure, tachypnea, tachycardia, sometimes absent pulses. We are still assessing circulation. Look for internal and external signs of bleeding. Bleeding could be in the chest, abdomen, pelvis due to femur fracture, GI bleeding in the stomach and intestine, and also external bleeding from any wound or trauma. Patient can present with shock due to pericardial tamponade. They can have hypotension, distended neck veins, and muffled heart sound. Don't forget to check the blood pressure. Managing circulation. If patient has a cardiac arrest, cardiopulmonary arrest, you follow CPR protocol. Those with shock and hypoperfusion, you resuscitate with IV fluid, sometimes use inotrope and blood product. And at the same time, you would like to do source control, applying direct pressure. If there is an obvious source of bleeding, you have to immobilize femur fracture and use pelvic binder, and you need to search for other source of bleeding if it is vaginal bleeding or postpartum bleeding, GI bleeding, and you need to assess if you are able to manage in your facility or to transfer. After you assess and manage airway, breathing, and circulation, you go to the disability, assess the level of consciousness. You can use AVPU scale if the patient is alert, responding to verbal stimuli, painful stimuli, or unconscious, and you can use the GCS in patient with trauma. Check for low blood sugar and hypoglycemia. Check the pupil size, reactivity to light, and if they are equal or not. Check for movement and sensation in all limbs, and you have to look also for feature of convulsion, repetitive movement, and shaking indicating seizure and convulsions. Managing disability. If there is altered mental status and at the same time there is no trauma and other component of the A, B, C are normal, you can place the patient in the recovery position. If patient has altered mental status and there is low blood sugar or suspected blood sugar, if you are not able to check the blood sugar and there's suspicion of hypoglycemia, give glucose. Those with convulsion, you use benzodiazepine. Pregnant lady with seizure, consider eclampsia, and you give magnesium sulfate. Disability management. If you see small pupil and shallow breathing, consider opiate overdose, and you can give naloxone as antidote. Patient with unequal pupil, consider increased intracranial pressure. You can raise the head of the bed, especially if there is no concern about the C-spine. And if unknown cause of altered mental status, consider trauma, immobilize the spine, and then you assess if you are able to manage in your facility or you have to transfer. After you finish the other component, airway, breathing, circulation, and disability, you have to expose the patient. Examine the entire body for hidden injuries, rash, bites, or other lesions. Rash such as hive can indicate allergic reaction. Other rashes can indicate infections. Exposure management. If a snake bite is suspected, immobilize the extremity, take a picture of the snake if possible and safe, and send to referral hospital. General exposure consideration: remove constricting clothing and jewelry. Cover the patient to prevent hypothermia. Acutely ill patient might not be able to regulate their temperature. Remove wet clothes and also respect patient modesty. If unknown cause is not figured out, remember trauma and you do log roll for suspected spinal injury. Take home, always do ABCDE approach in the structured and stepwise approach. Detect and treat life-threatening condition early. Whenever you detect something, fix it before you move on. Repeat ABCDE approach whenever patient condition changes or worsens. While doing airway assessment and management, don't forget C-spine immobilization. For breathing, make sure breathing is adequate, and whenever there is need for oxygen, give oxygen. In circulation, whenever there is shock and hypoperfusion, remember to use IV fluid, blood product, inotrope, and don't forget source control, especially in hidden organ like the chest, abdomen, pelvis, and femur, and inside the bowel. Disability, remember hypoglycemia, seizure, eclampsia, and when there is concern in A, B, C, consider recovery position. Full exposure is needed, and you look for rash or bites, and during exposure, don't forget about hypothermia and observe dignity.